much for joining this lunchtime session of Deepening Delivery, How Healthcare is Changing the Politics of Development. I think what's really exciting for us is first, this session is right in the middle of a geopolitical conference where we've got participants from across the world. So I think those of us who work on healthcare are very, very excited about it. The second thing is it's a full room. So that's really good, given that there are two other simultaneous sessions, and one of them in the Darbar Hall, which can seat so many people. So I think in this session, we're really lucky to have great speakers from different parts of the world with different skills and also different expertise. So what I'm going to do is just set the stage for 2 or 3 minutes and then ask a question to each panelist, give them about 4 minutes or so to respond, and then one general question to all of them, and then we'll open it up for questions from the audience, and finally a 30-second closing statement. So that's the structure. We were struggling a little bit when we talked about navigating the alpha century, but I think for the purpose of this session, we're going to stick to the decade. The next decade, starting from Jan this year. I think with the last decade, we've seen a lot of disruptions that have been good and transformative. Really, we've seen technologies in the use of healthcare. We've seen better use of data and evidence. We've seen elimination of some diseases. We've seen political leadership in others, and most importantly, we've seen some policies, global commitments, and we've seen the world move towards them. So from MDGs, we moved to the Sustainable Development Goals, and the good thing about this goal was really talking about integration, and it was talking about not looking at healthcare in silos. But at the same time, there are several concerns as well, and those concerns need to be addressed as we move into the next decade. I don't think, and I will let the experts speak to it a little more, we haven't done such a good job of managing disease outbreaks, whether we look at Ebola or whether we look at the measles deaths, or we look at the fragile health systems in some of the countries in the world still. We also are looking at addressing communicable diseases, but there is an entire epidemic of non-communicable diseases out there, and we don't know how to include that into our primary healthcare system. We also, I think the big challenge as well is the social unrest, and therefore a deepening of inequality and inequity, and how do we bring the whole idea of ethics and justice, the principles that underlined Millennium Development Goals, Sustainable Development Goals. And lastly, I think the big challenge really is how do we strengthen our systems? How do we share learnings across countries so that when we have oases of excellence or oases of successes around us, what can they teach us and how can that be shared? We haven't done such a good job of that, and I think as we move into the next decade, we have to. Our big paradigm shift is really the concept of universal healthcare. And the world has bought into it. Most of the countries are moving towards universal healthcare. And I think that's going to be our focus, because everyone talks about universal healthcare. Not many understand that it cannot be done in isolation. And also, most people recognize that strengthening systems, strengthening primary healthcare is going to be a big focus. So we are going to look at some examples from Sri Lanka or Thailand, and particularly from Malaysia, as you talk about your points. And with that, I'm going to start with my first question. Sandhya, my first question really is to you. And I want to, you are with the Gates Foundation. So Sandhya Venkateshwaran is Deputy Director with the Gates Foundation, and the foundation is really known for its statement about all lives have equal value, and that embodies all the principles that we are talking about. What the foundation also has made several investments and in different parts of the world that have seen remarkable achievements and that have changed lives of people. Can you share with us some of those investments, some of the results from those investments that have learnings for countries such as India or even countries in our neighborhood?
Thanks, Anjali. Is this on? Hello?
Yeah.
Hello? Yeah. Thanks, Anjali. It's a big question.
I
So
agree, and
let
4
me-
minutes is too small, but still.
Yeah, but so let me try and narrow it down a little bit to, rather than talking about the foundation globally, to how we're looking at India, what we've done here, and what some of the learnings have been, both from our work in India as well as actually global work, and what might be some of the disruptions, if we can call them that, going forward, right, to locate health more strongly in the broader development ecosystem, socio-political development ecosystem. So the foundation has been working in India for about a decade and a half, and a large part of our work in India is focused on health. So in a sense, that's really largely what we do, both from our own work as well as what's happening around us. I think it's safe to say that India, despite its size and complexities, has seen considerable progress in the health space. Over the last 2.5 decades, both infant mortality and maternal mortality have more than halved in the country, which is not a small feat. There has been, an addition of 10 years to life expectancy of a child born today as compared to a child born in early 90s. About 20% of the world's generics and 50% of the world's vaccines are supplied by India. So the point I'm trying to make it, polio, something as difficult as polio has been eradicated. So whether we look at specific diseases, whether we look at child and maternal mortality, whether we look at the manufacturing sector, India has a fair amount to say for itself, and India has done well. However, we can't be complacent, because actually the path to where we need to get to is still rather long and complicated. Just a few data points to give a sense of why we're still in a very, very difficult situation. That despite all the progress, even today, every 7 minutes an Indian mother dies from childbirth or pregnancy-related complications. Every 2 minutes an Indian baby dies before she's a day old. TB continues to kill nearly 1,000 Indians every day. All of this it's grim, it's complicated. A baby, looking at it from the equity lens, because like everybody in this room knows, India it's not one homogeneous entity. A baby is 4 times more likely to die in the poorest state in the country as opposed to the richest states. When we look at this healthcare ecosystem from a financial security lens, 4 to 7% of Indian households fall below the poverty line every year on account of healthcare related expenditures. So it's very clear that while yes, we've made progress, we've done well, there's a hell of a lot more that needs to be done. So the question then that the foundation has been looking at is, what are the next steps? What are some of the big leaps that need to be taken? As we look at the Indian healthcare ecosystem, we find that it's got 2 sort of parallel paths. One is the public delivery healthcare and one is private. And therefore, it's very difficult to focus only on the government system or on the private system, and there is a need to look at both. And as we began to do that, we found that there are actually, we're trying to examine what are the specific challenges of both that need to be addressed as we try to move forward towards improved goals, healthcare related goals. So just in terms of some of the drivers of, if I could call, state failures, one is of course adequate and efficient financing, and I'll come to that in more detail. The other is this whole notion of system capability. It's not necessarily only for health, it spans across many other sectors as well. But the capability of the system, whether it's health or others, is often not quite at the level that it needs to be. It needs much more optimization. And related to that is the whole notion of accountability. So financing and state system capability and accountability are three amongst many other sort of key drivers of state failures. Similarly, when we look at markets, the three sort of failures of three drivers leading to market failures are market fragmentation. When we look at the healthcare market today, we find that there is huge heterogeneity from the person in your drugstore who will provide you free consultation and actually give you medication, to small mom and pop shops, to healthcare facilities which have like 50, 60 beds, to gigantic mega hospitals that are attracting people from all over the world. So there's huge diversity and market fragmentation and very little regulation. So the result of very little regulation is that there isn't really an adequate ceiling on costs, and there is no base on quality. So at both ends there is a challenge, and the combination of these two leaves the consumer, the client, the customer, the citizen very confused, not knowing where to go, not knowing whether he or she is getting the right treatment, and ending up spending a large amount of money. So let me just pause there in terms of sort of opening thoughts. This is just some of the issues that we have identified and we are trying to dig deeper into. And as we move forward, Anjali, in the next sort of session, I'm happy to talk more about around these, what is it that we've learned from our own global work and the work of other organizations, and what that means for India.
Thank you so much, Sandhya. And Vinny, if I could move to you. This is Vinny Munene. She's the head integrated healthcare services for the Merck Group from Kenya. Vinny, I think one of the important things as we look at universal health coverage, or even as we look at achieving SDGs, the SDGs talk about a role of the private sector, the industry. And I know when you look at some of the innovations that have disrupted the last decade, most of them have come from the industry, from the pharmaceutical sectors. Today, if you're talking about drug-resistant TB, the drugs have come from the pharmaceutical sector. But yet, they're not seen as natural allies, and they don't naturally form a seat at the table. Why do you think is there, and what do you think can be done to change that?
Thank you, Anjali, and thanks, Aura, for having us here today. It's really an honor to be speaking in India Matters Health, considering that Kenya spends subsequently part of their healthcare expenditure in India. Also, just to put it in perspective, looking at Africa, we are 16% of the global population. However, we have to suffer 23% of the disease burden globally, with only 3% of healthcare workers available in Africa, and only spending 1% of the global total health expenditure. So yes, rightly said, disruptive technologies have to come into play, just to offer transformative potential for Africa, and so that we can be able to leapfrog and get to where all the other emerging and developed countries are. Seeing us as being the untrusted partner and not being invited to the table, yeah, you look at a couple of movies that have even been blockbusters, like Seiko and The Constant Gardener, The Fugitive. Always painting pharma, are the bad guys. As much as we are bringing such, innovative products, for example, vaccines, being able to eradicate diseases. So how do we do it? I think at some point we have to be intersectional, and we have to agree that we cannot do it alone. People have to stop working in silos. And I think what has also been seen is a shift of some of the companies and industries that are focusing also on healthcare. We have technologies companies coming in maybe they'll be trusted a bit better than pharma, and pharma is following the lead and looking at what technology companies are doing and trying to follow the lead. We have people like Google and Amazon trying to develop innovations for healthcare, either to drive prevention or even to be more specific in terms of treatment. Yeah, very focused treatments, genetics, and artificial intelligence being utilized by technology companies, and pharma is trying to catch up so that they're not, irrelevant in the next decade or even in this decade. For example, Kodak is no longer there. So we've seen a lot of pharma companies trying to focus also on technology and going beyond the pill, not just selling the pill, but looking at the holistic way of dealing with healthcare and dealing with a healthcare system. Looking at, pharma companies trying to drive healthcare education, trying to drive prevention. So when you speak from this angle, people are like, okay, they're not just trying to sell us medicine, they actually care about us. We've seen more and more pharmaceutical companies also being the front liners in terms of capacity building in countries, and especially in Africa. So they're coming maybe to the Ministry of Health and saying, yes, we have this particular product, but on top of selling you the pill, we are also going to train your healthcare workers so that they know how to diagnose, they know how to treat, and they know how to improve healthcare outcomes overall. And other things I could say is, companies now, pharma companies are actually collaborating together, so they're not doing it alone. When it comes to drug development and research, you have partnerships, for example, GSK and Merck trying to develop a product.
Yes.
And as you have rightly said, the SDG number 17 says SDGs for partnerships. So we are really trying to showcase ourselves in that arena.
Yeah. No, absolutely. I mean, I think very few people really talk about the amount of drugs donated by some of the pharmaceutical companies to address neglected diseases such as visceral leishmaniasis or lymphatic filariasis. So I think partnerships are very, very important. And Chini, I'll come to you next. Chini Ogunro is the Director of Health Research, Center for Study of the Economies of Africa in Nigeria. Chini, let's just focus on technology and partnerships with the private sector. I want to take this a little further because there is such a huge potential, a potential that is waiting to be realized in the next decade. What do you think are the challenges based on your country learnings? What do you think are the challenges for effective partnerships and intersectoral collaboration?
Sure. So I think that first it's important for me to kind of crouch my perspective in my experience. I wear two hats. So I'm both a healthcare researcher in terms of management research, operations strategy, how do you actually create sustainable healthcare businesses, but I'm also a healthcare practitioner in the sense that I operate facilities, I operate hospitals and clinics in Nigeria and West Africa. So looking at the way clinics, looking at the way hospitals are actually run versus the way maybe I would say the donor community, the general global health community thinks that they're run, there's a bit of a disjoint, a bit of a mismatch. So when we talk about technology, I know a lot of people, the first thing that comes to mind is really the traditional sense of technology. And that's like big tech, what you see in the Silicon Valley, all of the really cool apps that are coming out, some of the even, I would say, equipment type of technology. What are these technologies that you find really in developed OECD countries that are fantastic in making real waves in terms of how healthcare is delivered at the highest income levels? However, when you try to take those technologies and translate them down to the lower and middle income countries and how we experience healthcare, it's not necessarily the same. It doesn't always quite, it doesn't quite translate. For instance, one of my hospitals that I operate, we don't have electricity for about 16 hours a day. So if we're trying to apply these same technologies, it simply doesn't resonate in the same way. So I like to think of technology more in terms of innovation. I like to think of it more in terms of what are the actual either models, approaches, systems, and processes that we need to have, and we need to innovate around to get the sorts of health systems that we ultimately want. So for this type of innovation, what I see, or I think what I would ideally like to see, is really much more collaboration, many more partnerships that are coming into play, as opposed to the traditional way of delivering health that we see right now. So I think many people in the global health space, we've all experienced the same thing. You have the big donors, nothing wrong with the donors, because donors have done a lot of work, a lot of fantastic work to improve health outcomes over the past 2 decades. But we also see quite a bit of waste, and if we're frank about it, not 100% of every dollar, every naira, every whatever denomination you want to talk about, not 100% of it actually goes to delivering care to the patients or to improving the healthcare system the way we want it to. So as opposed to saying, let's move along the traditional route of working only with donors or partners, focusing solely on the public system, making sure that we go through these verticals of malaria or typhoid or preventing mother-to-child transmission of HIV and AIDS, as opposed to that approach, maybe there's a new way. Maybe there's a different model of how we can approach healthcare, specifically in low and middle income countries, that may look more collaboratively and more, I would say, cross-cutting, right? So for me, my theory of change has always been focused at the facility level, as opposed to sitting in a ministry where I did some work in Nigeria's health ministry, as opposed to sitting in the ministry and having the donor focus only on this money is going to go to malaria. I said, why don't we say, this money, whether it's from investors or from whichever financiers, why don't we say this is going to improve how we actually think of the facility sustainably running itself? How do we get the doctors, the nurses, the random administrator and managers who can actually have an impact on the way healthcare is delivered? How do we ensure that they're elevating the way that they're operating the facilities? And I think that sort of collaboration, you need to have a number of different people. You need to have the people who know how to operate facilities, of course. You need to have technology partners who may have fabulous electronic medical records or fabulous applications. You need to have, of course, financial partners. You need to have pharmaceutical partners. If I come back to Winnie's innovations, you need to have a number of different people who are sort of best in class or best practice for what it is that they do, coming together and ensuring that each and every hospital, each and every clinic, each and every pharmacy is actually functionally running the way it's supposed to. So that's really my own thoughts on technology and innovation and how we can really drive change into the future. Bringing together the right partners, focusing on execution and operational level efficiencies, and really growing that sort of system to create long-term sustainability across the health systems.
Thank you so much. Sridhar, is it okay if I go to Dr. Sweet? Because I really think your comments are going to be the ones cutting across what each panelist has said. So, Dr. Sweet Kaur, you are the physician on this panel and a senior fellow for Health Systems and Policy, University of Malaysia. I think one of the concerns that I mentioned right at the beginning was that our public health systems or our health systems are not strengthened enough to cope with the disease outbreaks. And that is a big concern, particularly when we look at fragile settings or we look at low-income countries, even in some middle-income countries. Malaysia, however, has done a fabulous job. And that's the Malaysian government's investment in their health systems. I remember 5 years ago when I went to Malaysia, it was one of the first countries that made a commitment to eliminate cervical cancer. And they started vaccination and a screening program. And it was incredible. I mean, their thing was that we want more women to bring their daughters for vaccination and more women to come for screenings. What was Malaysia's journey, and what can you talk about strengthening health systems?
Sure, Anjali, thank you. I'll track. Actually, I would like to begin with a couple of questions. I understand that many of you are fellows of the ORF, is that right? How many work in health? Excellent, I'll look for you later. How many work in international security, geopolitics, defense policy, things like that? And other areas are social sector, education, maybe? And other areas, say public-private partnerships, governance, administration? Okay, so I think we've covered most of it. You may not think that health is important to you, but it actually is. I'll try to use your jargon. And this is beyond just things like outbreaks, which Anjali has asked me about. But did you know that the American military is having trouble recruiting soldiers because of the obesity problem in America? Do you know that the Singapore Army, Armed Forces of Singapore, actually consider health as a determinant for how active or how, effective the military is in projecting power across Southeast Asia? So these are just how health intersects with defense, and I can just give all these other intersections, but I won't, because I'm going to go to the question that Anjali has asked, which is the journey of Malaysia. Very happy to share a small part of the journey. Health systems are generally local in nature. And there is a legitimacy issue in health systems, in the sense that if the state does not provide enough health services, then the state would see its legitimacy being eroded and therefore fail to project power or win elections. So this is one important consideration for why Malaysia's public health system is very strong. Secondly, there's a second characteristic in Malaysia's public health system, is that it's generally tax-financed. Because it's tax finance, it's more progressive in redistributing in three categories, yeah? Rich to poor is one, urban to rural is a second, and healthy to sick is a third. Now, these are important considerations because health systems are not just systems for you to deliver healthcare. They are political institutions because they define the social contract. Secondly, they're an economic institution because there's often a marketplace for services. Thirdly, it's a social and cultural institution because you're able to define how your average citizen experiences birth, life, death, disease, suffering. And if you put all these things together, health systems are not just hospitals and clinics and doctors, but they also form the fundament of legitimacy. I'll end with a final thought in my first preamble about Malaysia's journey. Malaysia's journey towards universal health coverage has been based on primary care. And I want to define two things over here by asking you one more question. Who has heard of universal health coverage, or UHC? Excellent, thank you. There is a difference between UHC, universal health care, and universal health coverage. The difference is very easy. Universal health care means that you get the care that you need at the level that you need. Universal health coverage, you get the care that you need at the level that you need without going bankrupt. Technologies represented by the people in this panel will inevitably be very expensive. But if you can ensure that your citizens are able to get the healthcare that they need without going bankrupt, then you're achieving UHC coverage. And how did Malaysia do this? By focusing on primary care clinics rather than hospitals. I end my initial preamble over here.
Thank you so much. I think, one of the most interesting papers I read was the problem of malaria amongst Indian soldiers in the border areas, particularly the northeast, that border, the transfer of malarian parasite. So I think you're right. Healthcare and security is very, very important. Sridhar, I think Sri made a perfect segue to my question to you and your work. You have been working on ethics, social justice, and inequity and inequality. And today we see the inequalities has actually become more rather than less, despite all the investments that have been made in healthcare. And the whole principles of equity and social justice as we attain universal health care or reach universal health coverage is absolutely critical. Can you share your thoughts on that?
Brilliant. So thank you very much for the opportunity to talk about that. Very rarely do people talk about ethics and equity so clearly. They always talk about technical problems and technical solutions.
And also within a geopolitical framework and conference.
Yeah, so I think, so I'm really excited about this panel and participating mostly because I started out in international relations And so it's really wonderful to kind of find this conversation. So for people who are interested in international relations, global relations, what does this conversation have to do with you? What does this have to do with your interests? So I'll give you three particular reasons. So a lot of people think that health is a domestic issue, and that is just no longer true. It's just no longer true either in terms of the empirical facts, and it's no longer true even in the conceptual way that we think about it. So three sort of concrete examples, which is that we thought that epidemics were over. They're actually increasing yearly, and the kinds of epidemics are changing. So it's not only the frequency, but the new kinds of epidemics. And internationally, epidemics are bad for international relations for two reasons, which is that whenever there is an epidemic, you shut down the borders, right? So this restricts trade, and this restricts the movement of people. So one of the reasons that Ebola in West Africa was such a heinous issue was not only because people were dying domestically, but the governments were very much against declaring epidemics, because this essentially meant that their entire trade and movement of people would also going to be shut down. So that is a geopolitical issue, is that whether a country is capable of preventing epidemics or dealing well with epidemics is not just an issue for health of its people domestically, but it's also very much directly related to trade and the movement of other people in and out of the country. So capital at this point can move without friction, but if you shut down trade of goods and services and people, capital will also stop coming unless they have some other very unique reason. So that's also one really issue. The second thing is that India and South Asia is in a very peculiar situation where it exports its healthcare workers into a significant degree. There's some statistics like there's more Indian doctors per American than there are Indian doctors per Indian, right? So it seems as though that there's, in a way, I haven't seen any calculations done about the amount of remittances that healthcare workers send back to India or to those countries, but it's significant. And so that is also an important transnational issue in terms of whether the movement of people, particularly healthcare workers, are moving back and forth and can move, and what and a lot of people don't recognize that remittances is development. It's a significant source of development income for various kinds of countries, and so that also has stuff. And the third is the impact that international trade is having on domestic health issues. So on the one hand, for example, India wants biotechnology to be its sort of forefront industry, but that requires a great amount of openness and coordination in international trade and protections and alignment. But also, it wants to develop healthcare industries which is meant for international patients. And so those are also, so there's numerous ways in which geopolitics and trade internationally affects the domestic health, but also other parts of the economy. So what does this have to do with ethics, and what does this have to do with equity? Is that if you leave things the way they are going right now, we know that health inequalities will continue to increase, which is that some people will maintain their health or improve their health, while other people will have bad health, or actually their health will get worse. So what's now happening is that it's not a question of either some countries are obese and some countries are malnourished. India is a very good example of where you're going to have both problems, where you're going to have malnourished people, but you're also going to have, undernourished people and overnourished people, right? And both of those are going to be affected, and both of those have international causal factors to it. So my ethics and equity part of it is not only to say that somebody has to care about the health inequalities that's happening in a population. If you just look at aggregate statistics, you're ignoring actually the great amount of diversity and inequality that's happening in a country. So is this an insurmountable problem? So I keep going back to this one thing, which is that I recently read a book about the actual logistical creation of the Indian democracy. And one of the core sort of parts of it is that while the Indian constitution was being written, some individual decided that every person would get a vote. This is that every individual, whether you're a man or a woman, would have a vote. And this is not a logical conclusion, right? So some people said each household should get a vote, or just a man should get a vote. But this individual made a choice that says in the new Indian democracy, every individual would get a vote. That is an ethical commitment, right? That's not an economic, that's not a stuff, that's an ethical commitment. And this country runs the largest elections and it coordinates them. And so 1 billion more people, and a significant number of them, are vote, illiterate or literate or whatever, they vote. So if you can carry out that sort of exercise where you make an ethical commitment that says every single person has a vote, and then the machinery is set up so that you can run these elections so that this vote is effective. So why can't you say every single person and every single person's health? And you run the machinery such that it does. So what is it that you can do this? So there's not like an impossible dream. It's obviously been done. So what is it that needs to happen in order to make that person make that ethical commitment that says every single person in this country is, has a claim or a right to health, and the machinery has to be set up in order to realize that particular commitment?
Okay. So we do have some time left, and I'm going to ask for short responses, as a continuation to the first question, because clearly that time wasn't enough, and there's so much we want to hear. And then I'm going to open it up for audience discussion and the last final 30-second comment. But Sandhya, let me come back to you. What are the learnings that you can share? Just one or two examples that you think that would be really that the foundation's work across the country has for us.
Thanks, Anjali. So just very quickly, building on what I shared earlier, I think one of the key high-level learnings is that for any country to achieve UHC, as we clarified, you have to engage both the public and the private sector. Some countries have a higher public sector, some countries have a higher private sector. India has a mix of both. Both are equally strong. It's very, very important to actually have an integrated system where you're working with both, because otherwise you have two parallel systems running, they don't speak to each other, and we as a country miss out on the opportunities of efficiencies and effectiveness. The second high-level sort of learning, and which leads to way forward, is around financing. Financing is always a very big issue. India, compared to other countries, allocates very, very limited resources for public health, and given the competing demands on its fiscal space, it is not entirely clear whether that would be increased. Therefore, it's very important for India, and similarly for other countries, to actually look at how do you get the greatest efficiencies and effectiveness out of the resources that are being spent. Large amounts of underutilized funds are sitting with the states, with the health departments across the country. There are policy drivers for that, there are capacity drivers for that, and fund flow drivers for that. Those need to be addressed. The other thing that needs attention in the context of financing is what is referred to as allocative efficiency. Where are the financing being directed towards? So again, we made the issue, he ended with a comment on the importance of primary healthcare. I could not agree with you more. There are many countries in the world, some we shall not name, I'm happy to name India, that actually focus on insurance for, as a means of addressing health. It's very important, it is very necessary for any government in a country. The key thing to actually analyze and assess is what is the greatest ROI for public resources. Is it in primary care? Is it in tertiary care? Within the health sector, is it on what's referred to as public health goods? So for example, air pollution is a public health good. Clean water is a public health good. It's going to be very difficult to find markets interested in those. That is where the government needs to allocate its resources. So those are a couple of sort of priority areas.
Okay. All right. Thanks. It's sweet to come back to you. I know you set out your preamble, but I would like to push you a little more and say that one of the things that Malaysia has done very well is set up this health systems for its population. But at the same time, we do see a lot of climate disruptions. We do see natural disasters. And how can countries not only establish systems that can, meet the health needs of people in times of disaster, but also help other countries to do it? So, short response for that, and then.
I'm a bit speechless right now because climate change, climate resilience, refugees, climate migration, these are all very challenging topics to resolve in about 30 seconds. So let me try.
I'll give you 2 minutes.
Thank you. The lessons from Malaysia is not really prepared, but then again, no nation is really prepared for what's going to happen in the climate emergency, and the emergency is real, it's happening in front of us right now. We, as in Malaysia and many other countries that you represent in this room, also have similar problems that you can't even deliver not you, but we can't even deliver basic healthcare, primary, secondary, or tertiary levels to the existing people in communicable and non-communicable disease settings already. If you throw in the third burden of climate change and environmental changes and stresses of migration and so on, it can threaten to overwhelm health systems, especially if you put in urbanization. So I'm just setting the scene for it. Maybe I'll bring 2 points over here. The first point is to say that there still remains a need for primary care in response to any challenges to the health system. If you have a resilient primary care, they can do 2 things very well. Number one, they will make sure that the hospitals are decongested so that you can have those hospital beds ready in the event of an emergency or an outbreak. Second, the decongestion, that is the term. The second thing that primary care can do is to save cost. A hospital stay, to build a hospital bed in general, it costs about 1 million units of your respective currencies in general terms. So it's like 1 million ringgit in Malaysia to build 1 hospital bed. And a hospital could be 1,000 bedder, then you're looking at tens of millions of dollars just building a hospital. But if you invest in primary care, it's a way for you to save money in the future. So this is one important element, and I return to the theme and I pause here again.
Thank you so much. I'd like to ask both of you, Vinny, and to really talk a little bit about the whole private sector partnerships and technologies. I mean, there is a general perception that technologies are expensive, and therefore governments can't use them. And so, they're just there for those who can pay them, which again brings in a certain amount of inequality. Do you have any suggestions about, or any comments on this point? Both of you to respond to this.
I think there is a solution. The WHO Committee for Social Determinants for Health says one of the biggest issues that are causing health inequities is things like bad politics. And, just a lack of focus and, other things that could be easily resolved. So as we could rightly say, the money is there, but it's not being utilized well, right? There's a lot of issues of corruption, there's a lot of issues of leakage of budgets and etc. But if there was a political commitment and public health is a political choice, there would be a lot of streamlining that would allow governments and even private individuals to afford health technologies to advance their healthcare status and situations. So I think the most important thing here is to look at efficiencies, and private companies, private pharma companies, healthcare technologies companies are looking at different business models to engage with governments and even low-income population governments, looking at how they're able to afford and how they can pay, and case-to-case individual basis, see how they can sort of be able to avail these technologies in the countries. So we are looking at leasing models, we are looking at pay-per utilization models, and therefore it's not a huge capital expenditure to the governments if they were willing to do it in the right way. So I think it's very possible.
So I take a very similar approach, and I fully agree with what Winnie just said. But I also want to inject into it the element of this aspect of innovation and entrepreneurship. So there's a question around who is actually developing these technologies and who is actually able to innovate around certain problems. So if we're only trying to transfer knowledge from high-income countries to low-income countries, and then we're more likely to fall into that problem of lack of financial access to these technologies. But if we're actually empowering our populations, I would say the lower to middle income populations, if you're empowering them to be able to drive forward these innovations, to be able to come up with solutions that are relevant for their communities and their families, then I think you're more likely to be able to see a bit more equity and a bit more relevance of how we implement and how we use certain technologies. And if we're also able to simultaneously ensure that you're able to scale, or whether it's public sector support for scaling these technologies or private sector support for scaling these technologies, I think it's really just important to ensure that all people across all income levels are able to innovate and provide these or develop the right technologies for the right problems.
Yeah. Sridhar, the problem about inequality in access to healthcare is not just a developing country problem. You see those debates and discussions happening in the US and UK as well. What can you say about what can you say a little bit about the ethical dilemmas that supposedly the countries are facing, but really shouldn't?
So I think, how many of you are Americans? Okay, so I don't know how many of you would say that it's an ethical dilemma as to whether people have access to healthcare in the US or not. So I think most industrialized countries, except the United States, every citizen has access to health care, right? So there's a different question beyond the basic access to health care, which is at what level do they stop getting funding for the healthcare that they need? So the ethical dilemmas are there in terms of the idea of a limitation on their amount of public funds that they can have on access to healthcare. And that's a really difficult ethical dilemma. So from an ethical philosophical perspective, if somebody was sitting around and making decisions, they would say, okay, so I have to decide whether someone who needs it urgently, someone who could benefit it greatly, or helping as many people as possible. And then I would answer, it also matters to me how this health issue came about. Right? Did they have some sort of choice in it, or was it that we created their health issue in the way that we've constructed the environment around them? So it's very hard for us to actually make a priority about these four criteria. And I think that requires a way of decision making that allows social values to be input or make some brilliant solution to this problem. So that's the solution for rich countries. I think in low and middle income countries, it's a similar kind of problem, which is that there's too many people that need health care now for illnesses and diseases. And there's a limited amount of money, and there's no control over that money in a single agency. So even if the government has some control over it, they have to make priority decisions about their allocation of resources. Then they also have to deal with these international, whether it's governments or philanthropic foundations, who also have their idea of what they think is important to do. So how do you negotiate those kinds of stuff? And what's happening is that we also have this problem of, do we address the disease where people are suffering from, or do we prevent disease in people in the future? And that is another ethical dilemma of how do you make a trade-off between suffering now or preventing suffering in the future. And I think that in many countries we also have a lot of contextual ethical dilemmas. So I want to just, my job as an ethicist is to point out problems. So I'm going to point out a problem here, which is that people talk about primary health care a lot. And so I work with surgeons, right? And so the question is, why can't poor people have surgery? when they need it, right? A significant amount of diseases and things require surgery, but for decades, we've been telling this thing, oh, if you just give people these basic primary goods, you'll have more stuff. But so what you're basically saying is that surgery is not for poor people, right? And so I think there's something wrong in that. So there has to be a different way of thinking about how do you meet the healthcare needs rather than saying, you know, basic things for poor people versus, you know, other things for richer people. So
Totally agree, and you're right, that's a big question. So I open it up to the audience. We've got about 8 minutes, or maybe 4 to 5 questions, and then I'll take 30-second comments from. So I have 1, 2, 3, 4, and so let's go with these 4. Could you say your name and organization?
Okay. My name is Priscilla. I come from Kenya, and I work for Robert Bosch. I just wanted to understand really, I can give you a scenario of what happens in my country. If
so
I go,
a quick question, because we
it's
don't
quick,
have
I'm
too
talking
much
very
time.
fast.
Yes.
So if I go to a chemist today and buy maybe an antibiotic, I'll have 2 options. There's a generic and an original. So really, I don't understand if a product is working and it's from a reliable manufacturer, why is it generic? And what is the point of having generic and original? And also, quickly, I also wanted to talk about the cost. The cost is quite high for medicine. And really, I want to understand what are the cost drivers for medicine? And why is there variability when it comes to the cost when you think about, like I said, generic and non-generic? So what is the cost drivers, really?
Yeah. Should we take the questions and then do the answers? So that's the first. There was someone back there. Yes. Yes. Sir.
Thank you, and thank you all so much for this wonderful presentation over lunch, and a very necessary one. My question has to do with, I think, what it takes to build trust with the communities that a lot of this work is taking place in different theaters throughout the globe, and in particular in the context of a lot of the themes of the alpha century that this conference has been talking about, amid sort of rising nationalism, strongman leaders, disinformation. How does that sort of play into building the necessary trust when we have sort of rising questions, skepticism in the U.S. about vaccines? I want to say it was a polo vaccine worker that helped target a military strike in Pakistan a few years ago. These types of issues and how they play into this work.
I think that's a great question. There was someone there. Yes.
Yeah.
Yes.
Lucas Bauer, I currently work for the German Development Agency in Myanmar. My question, I'm very thankful, Mr. Professor Sridhari, that you mentioned the problem of malnutrition, because I believe it's one of the most crucial ones related also to health, but not only be related to health, because we have around 150 million children that are stunted, so meaning they did not receive the right amount and the right mix of nutrition, and that means that their cognitive capacities can never, ever develop, which will have obviously quite some tremendous effects on society.
Questions.
Can you please give some recommendation based on your research in which direction policymakers on the one hand and those who are working on health should tackle this issue? Thank you.
Yes, and you.
Thank you. It was a nice and excellent panel. My question is...
Your name and organization.
Thanks. I'm Nandini Tandon. I'm from the Silicon Valley. We are here to launch the Silicon Valley's report. Oh,
Okay.
Sorry. Thank you. I'm Nandini Tandon. I'm here from Silicon Valley. We're launching the Silicon Valley India report as to how we can work better between the 2 areas. One of the areas is healthcare. My question to all the panelists and whoever wants to field it is that we all know that we need equity, we need private-public academic partnership, we need all the different aspects that you talked about. Why is it that in this day and age, we still are raising the questions and not getting the answers? Why is it that we don't have the partnerships that we must have? What do you think is the obstacle? Thank you.
Okay. So I think we've
Sorry,
got the
may I just one
Yeah.
last question?
Yes. Okay. So we'll take these 5 questions.
Yeah, no, it's more about the theme a bit, carrying on what you mentioned. Within the public health sphere, we often talk about, or the public health system, we talk about the 6 building blocks, but we often leave out the 7th, which are the patients. So thinking about the alpha century and what is coming with the technology and the social injustices that we see, how do you see patients' role in the future health systems and their voice.
Thank you. Thank you. So we've got about 5 minutes, and there are 5 questions, and I would request any of the panelists to take one question at a time. Okay, so why don't we do that? Is that good? I mean, we could just have the panelists do closing remarks, and they can respond to the questions. Great, that's a great idea, Sandhya. And why don't you go first?
I wasn't a bargain for that. So let me begin by responding to one question, Nandini, yours. Why is it that for so long we are still talking of inequities? And that's actually a great question, but a complex one. And I would say because issues like healthcare, in fact, as Sridhar mentioned, they're not just about access to healthcare, right? It's about so much more. It's about power. It's about social justice. It's about politics. It's about economic status. So till all of that is addressed, which is actually so complex, the inequities in healthcare may well remain. I know I'm not doing justice to your brilliant and complex question. But just in terms of closing, I would just like to underline the importance of health. Why we're even talking about it, because while in itself it's very important for the quality of life, it's a right, but it is linked to so many other aspects of our life. It has to do with education, it has to do with productivity, because it has to do with cognitive development, it has to do with the ability to gain employment, and at a national level for a country's economic growth. There's enough and more studies that have actually shown the links between health and nutrition and income generation at an individual level as well as at a national level. So I think the world is at a stage where we recognize that health is linked with many other aspects of life, and we really need to look at it seriously.
Who would like to go next?
Yeah. So I'm going to try to answer the questions about the generics and the innovator drugs and the cost drivers for medicine. So why generics? So generics come in to try and drive the issue of access and price and affordability. And they have their place in the market because otherwise, if there weren't innovators, there wouldn't be generics. So companies spend a lot of resources and investment in drug development, and a huge amount of time. We look at about 15 to 20 years. It's now reducing, with the availability of technology and AI and machine learning. The number of years to develop a drug is reducing. However, the cost is still very significantly high. First of all, you bring the product to market after 15 to 20 years, and then you have to still continue, working on issues of quality and looking at things like side effects and adverse effects in the market. And therefore, you cannot just produce a drug and leave it in the market without follow-ups and drug development follow-ups. We look at things like medicine is the second largest cost when it comes to healthcare, number one being healthcare workers. So how we sell medicine is not the same way we would sell, cars or a hotel room. You need to work with healthcare workers to sell medicine, to be able to give proper medical information to the doctors that will be prescribing this. And this is mainly driven by innovators. Generics just come and fit into a box. So we definitely have, there's a place for innovators, and this is to drive innovation and to drive research. But generics, then we allow them to come in and to drive affordability, especially, after the innovator companies have sort of recouped their investments.
Yeah. Thank you. Would you like to go next, and then we do the closing remarks with the two of you?
Thanks. Mindful, I just have a few minutes left. I'll try to give a whistle-stop tour of the answers and then end with 3 thoughts. The first one is, why are generics not used more? Political reasons. Also, a fact for all of us is that 8% or 9% of total healthcare expenditure is medicines. So we have to attack the other 91% as well and not just focus on medicines. Number 2, how can we build more trust in healthcare for doctors to be more visible and for politicians to take a back seat? It's unfortunate that the assassination of certain leader back then, gave us problems with vaccines today, but I think if doctors step into the fray a little bit more, I think we can build more trust. Thirdly, what are the recommendations for malnutrition? Another one of those great questions for which are very difficult to answer. Two things as we can explore this. The first one is the best determinant for population health is not more hospitals or doctors, but rather poverty eradication. So anything you do with poverty eradication would be great. Conditional cash transfers would be a second idea. To Madam Anandi's question, what are the obstacles to public-private partnerships? And I give two. The first one is ethically fraught to profit from healthcare. Secondly, politically very contentious, and therefore we don't have a good model for how we can work right now. Finally, the question about the seventh building block for patients. I love patients. They should get into the action a lot more. From being a passive recipient of health services in a very feudal society, very paternalistic healthcare system, they should be more engaged and more active. I leave you with three thoughts, if I may. The first one is that health is a political choice. I'm not going to explain these thoughts. Health is a political choice. Number two, health needs more stature, the ministry, in relation to, say, economics or defense. And thirdly, if you put health in all policies, you should be able to get better health systems for yourself, more legitimacy, also more geopolitical safety. Thank you.
So, Sridhar, you and Chini, just
have the
quick
last word.
thoughts.
Let me go first. So I want to address the trust, the malnutrition, and the patient.
And very
three questions.
quickly, yeah.
Very quickly. So the trust thing is that, look, you might know about this polio operation and stuff. Most people in India in the bottom of stuff don't know about that. What they care about is when their child is sick or they're sick, they want to go see someone that's going to solve their problem. If you can solve their problem, then they're going to trust you. What they're not going to do is that if you give them an injection and say, oh, this is going to prevent a problem from happening, that's very hard for people to understand. So if you can actually say, look, your child needs a vaccination, you might not appreciate that, but also solve the problem, which is their child is sick or they are sick, and you do it effectively and dignity, and they'll come back with the trusting, and they'll trust you more than anyone else in the community. The malnutrition problem is that, you get two choices. You get 0 to 2, or actually it's -9 to 2 years old is when you can actually make significant, and adolescent, right? So my thing is that, the height is the best indicator of well-being of an individual. That's what you can tell about how well a person's going or how well their nutrition and life is going. So the country with the best height, anyone know? The Netherlands, right? So everybody talks about Japan being the longest, but it's actually the Netherlands that has the healthiest people, and their problem is that their people are too tall. So their beds are too short and all this stuff. But why are we not focusing on what the Netherlands does in terms of the way that they follow children from 0 to 2 in adolescence to ensure that they're growing, they're well-nourished, and also they're -9 to childbirth? So that would be one trite, but I think a really effective thing. The patient-centered stuff is that you're asking, and I agree with you, that you should actually shift the paradigm in public health. Public health doesn't care about people, it cares about prevalence levels, right? It cares about aggregate numbers in terms of epidemic control, levels of disease, and so to make the patient, the individual, the center, requires us to really rethink about what's the purpose of public health. Is it to control disease or to make individual and population lives better and healthier? And I think those require two dramatically different ways of doing it, and I think some of us are working on it, but it just doesn't fit with an efficiency or the disease control prevalence. But I think you're absolutely right to point that out as being important.
Chini?
Our time is completely up, and I'm going to make mine as short as possible. I think everybody has already answered the questions that have been had quite well. I simply want to take this time to really advocate for more collaboration, more bringing together the right people who have the right knowledge, and the best practitioners in different areas of healthcare to actually work together, and also more cross-geography collaboration. I think there's a lot that different countries can learn from another, a lot Nigeria can learn from India, a lot India can learn from Bangladesh, a lot that the US can learn from other countries in the global south. So I just really want to thank everybody, all of the other panelists for their time, but also really advocate for more collaboration.
Thank you so much. I'd really like to thank the ORF for including this session in a geopolitical conference. More mainstreaming of health is important. And one point about vaccine hesitancy, the WHO DG has said that is one of the biggest threat to disease outbreaks. So with that, a big, big hand for the panelists. They've been amazing, and thank you.